When you think about estrogen, what comes to mind? Periods, pregnancy, hot flashes, menopause. That's what we're taught, that estrogen is a reproductive hormone, that it helps pregnancy, it's connected to your period, and that it starts to decline later in life. That's true, but it's also wildly incomplete. Estrogen is found in nearly every major organ system in your body. Your brain, your thymus, your lungs, your cardiovascular system, your lymphatic system, your blood vessels, your kidney, your liver, your colon, your muscles. This is why, as estrogen in our 30s, 40s, and 50s starts to fluctuate and decline, which happens about 8 to 10 years before a woman's last period. On average in the US, a woman's last period is around age 51. So this can be for a decade, sometimes more. This is why when that period of fluctuation and decline happens for women, they have symptoms and effects all over their body. The estrogen receptors that have been there waiting for a signal from estrogen since puberty have been in kind of an equilibrium across your body start to go haywire. Today, we're going to learn about three things. Number one, what is estrogen and where does it operate? Number two, what happens when it starts to fluctuate and decline in midlife? And number three, what you need to know to do something about it. Let's start with estrogen. Estrogen receptors are found all over your body. Why does this matter? Your cells communicate with hormones through receptors. Receptors sit on the outside of the cell and receptors sit on the inside of the cell. When estrogen is floating around and that hormone binds to the receptor, it tells the cell to do something differently. And since estrogen receptors are essentially everywhere, all these organs in your body have been receiving estrogen and acting in a different way as a result of that estrogen. There are actually two types of estrogen receptors. To get a little more specific, there's estrogen receptor alpha and estrogen receptor beta. Alpha is found reproductive organs, bone, liver primarily, and betas are found all the other places. We've talked about estrogen receptors being found, which is, again, essentially everywhere. What does this mean in practice? Well, it means that estrogen is not just doing one job. It's actually doing a lot of jobs simultaneously, all the time, all across your body. And when estrogen starts to change, your body changes too in lots of different places. So what does estrogen do in these different places? Let's go organ by organ. Let's start with the cardiovascular system. Okay, blood vessels. Estrogen helps to maintain the elasticity of blood vessels. We like elastic blood vessels. We like blood vessels that are more pliable and responsive to changes in things like pressure, like blood pressure. It does that through nitric oxide that helps to relax and expand. Estrogen also helps protect the endothelium, that's the lining of your blood vessels, from damage and inflammation. Estrogen also has favorable effects on cholesterol. So cholesterol has a few different parts. LDL, we want to be low, like the letter L. HDL, we want to be high, like the letter H. Estrogen actually helps to make your LDL low and your HDL high. And then it does something else. It goes a step beyond. On the LDL, when LDL is oxidized, it's not just elevated. That LDL particle can be dangerous. Estrogen reduces oxidation on LDL. This is often why I find that women in midlife, one of the first signs that estrogen is starting to decline, that they're in perimenopause, is when I start to notice changes in their cholesterol, even slight shifts in the LDL going up and the HDL going down, even in women who haven't changed lifestyle or habits or food or exercise or anything else. This is part of the reason why women before menopause have much lower rates of cardiovascular disease than men of the same age do. It's also probably why 10 years after menopause, women equal, if not surpass, men on cardiovascular disease risk. Estrogen is cardioprotective in the vessels and blood vessels all over your body, as well as in your heart itself. Now let's talk about your brain. Obviously, matters a lot and gets underreported in the context of estrogen. Estrogen receptors are concentrated in 4 distinct areas. First, the hippocampus. That's our memory center. It's then concentrated areas around mood regulation, executive function, and sleep. If this rings a bell for anyone in perimenopause, let's talk about executive function. What does that mean? It's like I made a plan to go to the grocery store. I wrote down the list. When I got there, I got every item that I needed. I checked out, I left, and I came home. There are a lot of things in that process that require executive function and focus. That's the type of thing that women in perimenopause can start to notice. When estrogen starts to decline, many women start to notice those brain-related changes first. Changes in sleep, in memory, in cognition, that brain fog that many people talk about. These are real symptoms and they have a neurological basis. Estrogen supports the production of serotonin and dopamine. These are our happy hormones. Estrogen also has neuroprotective effects. It helps to increase the synaptic plasticity, essentially the ability to strengthen connections as the brain every single day is building new ones. These neurological symptoms are not anxiety, they are not aging. This is the brain adjusting to a new hormonal environment. Your body has had estrogen circulating all over since what, puberty? 12? Dr. Mosconi found that in women, not just 5 years after menopause, but more than 10 years after menopause, their brain is still lighting up with estrogen receptors. The brain is still hungry for estrogen. 2/3 of cases of Alzheimer's disease are in women. The biology of why that is still being worked out. But the timing, estrogen decline, and the timing of Alzheimer's onset are likely not completely a coincidence. Okay, let's move on to bone. Osteoclasts and osteoblasts. Blasts, build things. Clasts, cut things. Estrogen inhibits osteoclasts. It inhibits the breakdown of bone. Estrogen helps osteoblasts. Estrogen helps build bone. Your body is always in this continuous cycle of bone breakdown and bone reformation. But as estrogen starts to decline, both the inhibition of excessive cutting and the absence of a signal for more bone building is likely why women have higher rates of osteoporosis and why the onset of osteoporosis, osteopenia, often comes with and after the menopause transition. Let's think about this. When estrogen declines, this equilibrium and this balance shifts. Women can lose 20% of their bone density in the first 5 to 7 years after menopause. Osteoporosis is overwhelmingly a woman's disease. There's no amount of calcium you can intake to overcome the loss of estrogen. Muscle tells a similar story. Y'all are really going back in the science here. Mitochondria, okay. Mitochondria, the powerhouse of a cell, are the energy producing machinery inside your cells. They help with muscle building and muscle repair after exercise. Women who notice they're losing muscle in midlife or taking longer to recover, oh my gosh, like how far could you run before without needing a recovery day? That's not a coincidence. It's not normal aging. This is often connected to the loss of estrogen that was supporting the mitochondria and our skeletal muscles with their building and recovery of our muscles. Here's the metabolic piece. This connects to exactly what we talked about when we discussed cardiovascular kidney metabolic syndrome. Estrogen plays an active role in insulin sensitivity. That's how well your cells respond to insulin and how they manage your blood sugar. Estrogen influences where your body stores fat. When estrogen is active, fat tends to be distributed around our body. As estrogen starts to decline, fat tends to concentrate more in the viscera, the areas around our organs, and in our midsection. This is not just you not able to lose the pooch, right? This is a hormonal change and shift in our body as the result of estrogen decline. The shift in fat distribution is not a lifestyle change. You can't lifestyle your change out of estrogen decline. This is body shift in response to changing hormones. Fat in our midsection and around our viscera or organs is not just a metabolic signal or shift. It is also a risk factor for cardiovascular disease, insulin resistance, CKM syndrome. Your BMI may not have actually changed. And by the way, BMI is not a great way to know about where fat is in our bodies, right? But your risk profile may have changed even in the absence of a BMI shift, all because of where that fat is distributed. Okay, On to what happens in perimenopause and menopause. This is what I think catches a lot of people off guard and has so many of my friends wondering, is this perimenopause or not? Perimenopause, which is the transition to menopause, menopause is like one day, right? The day that is a year after your last period. That's literally one moment in time. Perimenopause can be a decade, if not longer, and it starts often in our 30s when we still have regular periods, when we still feel just fine. The estrogen starts to wildly fluctuate. The highs are higher and the lows are lower. What are some examples of that? I have patients who have new onset or start to have really bad migraines as they hit perimenopause because that's actually because the estrogen is swinging wildly high at times. I have patients who have new skin conditions, rosacea, eczema, contact dermatitis, things that start to come up because of that estrogen swing. You may not be fully heading towards estrogen decline yet, but those swings alone can change how those receptors all over your body, what they tell cells to do. All of this is to say that these hormone fluctuations start before the symptoms come. The brain and the cardiovascular system start to register these changes and start to feel these metabolic shifts even before steady estrogen decline. This is what I think most women have no idea about. By the time a woman notices hot flashes or sleep disruption, the biological transition has been underway for years. This matters because the window for intervention, the window for starting to think about things connected to perimenopause, starts way earlier than you think. And it starts way earlier than most doctors think. The conversations about cardiovascular risk, cognition, bone health, metabolic health, these are not conversations to wait to your 50s to have with your doctor. These are conversations for your 30s, your 40s. What is my risk? What are the things that I need to be doing? And what are the things that I need to be aware of to protect my heart, my brain, my bones, my skin, whatever it is that matters the most to you and that you personally are at risk for? I want to be clear about something because I hear all the time, like, oh my gosh, I just need hormone replacement therapy, menopausal hormone therapy, that it's a magic bullet. Don't get me wrong, it's amazing. And it is part of the right answer of a portfolio of options for many, if not most, women. That said, hormone replacement therapy, menopausal hormone therapy, it's all complex. We'll talk about it at another time. What I'm describing today is a biology of what estrogen does. When you understand the biology, you can start to understand why things might be happening in our bodies as estrogen starts to fluctuate and decline. You can make informed decisions. You can ask better questions, and you can not feel dismissed when you're worried about something and want to bring it up with your provider. I also want to add, even if something is connected to perimenopause, doesn't mean that it doesn't deserve its own diagnosis, evaluation, and treatment. What I mean by that are things like your cardiovascular risk. Yes, it goes up by perimenopause, but that should not be an excuse for us to say we are not going to do a full prevent score, a full risk assessment on you, and make sure that you are protecting your heart in all of the ways that matter, including and in addition to medications like hormone therapy. The symptoms that you're feeling, even if they're connected to perimenopause, like brain fog, sleep disruption, it doesn't mean that you don't also need to understand, evaluate, diagnose, and treat that symptom. So I think this is really, really important because calling a telehealth clinic for a hormone patch to help with symptoms could be really great for you, but also it may miss the things that are, one, most likely to kill you, like making sure you're truly protecting your heart and your brain and your immune system, things like that. So what I would encourage you to do is, now that you understand more about the biology of estrogen and all the things it does in your body, if you're starting to notice things that you think are related to estrogen decline, incorporate that into your conversation with your provider. Absolutely. Also, do not accept that hormone therapy alone is the solution. Here's what I wanted you to take from this. First, if you're in your late 30s, in your 40s, in your 50s, and you start to notice things like new migraines, skin changes and dermatitis, fluctuations in weight, energy, mood, sleep. These may be connected to fluctuations and decline in estrogen. It's worth bringing up and naming with your doctor. It is also, though, important to make sure that the underlying things also connected to estrogen decline, like your cardiovascular risk, other cognitive risks that you might have, are evaluated, diagnosed, and treated as maybe a part of perimenopause, but a separate, important, and often like a really big issue. Second, unrelated, cardiovascular risk, bone health, metabolic health. These are not things to start tracking at 55. These are things to start talking about and assessing your risk for now. Ask your primary care doctor, what's my cardiovascular risk? What's my prevent score? What's my bone health profile? What's my metabolic profile? Give me my DEXA scan. These are all things that, these are fundamental questions. Ask them now. Third, if your doctor dismisses your symptoms as stress or aging, or says, oh, you just need menopause therapy, it's a patch, find another doctor, right? You don't need to be dismissed. You don't need to sort of not get the full things that you need as a woman in perimenopause. It is not just about the hormone therapy, and it's not just stress, it's not just anxiety, it's not just aging. You deserve a full picture. You deserve a full clinical picture of your health and an action plan for what you can do about it. When estrogen starts to change, and it starts to change probably earlier than you think, your entire body feels it. You're not malfunctioning. Let's be clear. This is biology. But biology that's understood is something that you can do something with, something you can take to ask more informed questions and advocate for yourself with your doctor. More to come. And hey, subscribe so you don't miss